You'll be next.
I'm Arnold Mazer. I'm a primary care physician. I have worked my whole career in a university health service. I have seen many young women who have a variety of symptoms, some of which are vague. Um, I've heard here today from physicians whose life work is dysautonomic syndrome saying it isn't easy. There are so many different manifestations. The studies haven't been good. The treatment isn't good. I've heard from some wonderful women who have terrible stories about having gone through years. And so, question I have, what is the downside of making the diagnosis earlier rather than later? What's the downside? The treatments that I've heard, for the most part, are not the ones that I've heard from the patients. Either they help some, they help a lot, or they don't help at all. Treatments that the patients have described. The treatments that the physicians have described, same thing. Not much scientific substantiation on any of them, and no clear guidance. So why not diagnose it early?
Okay.
And maybe misdiagnose a lot. However, we don't have a condition where the treatments that may help are harmful,
Okay.
for the most part.
Christy,
Christy,
well, I
well, I
think the
think
way
the way
to
to
I deal with this, and as I said, we don't have a lot of time, and I think there are people who want to ask questions. I'm going to have one physician answer and one patient advocate answer for each question. So, Chris, do you want to, and feel free to punt back to me if there's anything you feel uncomfortable answering.
So I think I think you make an excellent point about an early diagnosis, and that can be helpful. I think one of the cautions I would say is you don't want to necessarily miss another diagnosis in the kind of rush to make a diagnosis. So particularly when other treatable diseases exist, if we miss those, obviously we're doing a great disservice. So I think that's why a timely diagnosis is critical, but as much as possible, you want to hone in on obviously identifying what is appropriate and what would be the best treatment here.
Yeah. So, who wants to answer that? Remember, you may not get another question, so pick the one you want wisely.
I'll take this one. So I think that we want people to be diagnosed as early as possible because that can avoid suffering and maybe prevent some of the deconditioning. But I also, like the doctors, don't want doctors to rush into the POTS diagnosis. In my own case, POTS was diagnosed, and it took another year before I could get to a really good autonomic neurologist who said, "Nah, you actually have Sjogren's syndrome." And the treatment for that is the symptomatic treatment for the POTS part of the symptoms was the same, but the underlying disease treatment for Sjogren's for me was immunomodulatory therapy. So that's very different than what we talked about today for POTS. So you wouldn't want to throw out a POTS diagnosis too quickly. You want to make sure that person doesn't have some kind of other condition, sort of exactly what you just said. So that's my answer.
Yeah, I think that's those are two very good answers. I think one message that I think did come through, and Chris expressed it very nicely, is that we have on the one hand postural tachycardia syndrome, but you do need to look for an underlying disease. And you also do look for, you do need to look for comorbid aspects of the disease, because you're not just treating one entity, but accuracy is vital, and you don't want to jump to make a diagnosis when it may be the wrong diagnosis. Next question. Oh, I promised you, yeah.
So what are the key special diagnostic tests that a primary care practitioner can do? And if they have high suspicion of POTS after that, would the referral be to a neurologist to do the tilt test? It seems like it's hard to find the right specialists. They don't have openings, and so specifically thinking about the Boston area, like who would be the person that you turn to?
Okay, do you want to go with that one?
Sure. So, I think in most cases, as we sort of talked about a little bit earlier in the diagnostic criteria, simple lying to standing test requiring no special equipment, just measuring pulse, lying and standing is a very simple test that really can be done anywhere. And that's very helpful. Again, that doesn't give you the answer as to what's causing it. It gives you a direction, a potential area to look into. So as a disorder, that's helpful to understand. And then certainly in a primary care physician's office, they're very capable of evaluating the initial steps. Is there a thyroid problem? Is there is there some GI illness that may be contributing? Starting some process in this. If there's a point where you're unable to make progress beyond that, that's when thinking about a referral to somebody else locally. Certainly in the Boston area, we do have a number of medical systems. We obviously have a specialty center here. There's neighboring centers at Brigham and Women's. There's Mass General has autonomic, kind of smaller groups, but they exist. And so I think in those cases, particularly in other areas where there aren't autonomic centers, our center, for example, is probably the largest, and then till Vanderbilt. So there's a long distance between big centers. Then you have to look at local specialists, neurologists in general, cardiologists in general, and that's where I think you have to search for local assistance when necessary.
Yeah. So, and I think I'll keep this with the physicians unless, Lauren looks like she has something to say. I think when you have a patient who you suspect has a disease of the autonomic nervous system, you do want to do autonomic testing. And I think it's really quite critical because not every patient, I know you come to a symposium like this and you think presence of a symptom of dysautonomia is equal to POTS. That would be a mistake. There are many disorders of the autonomic nervous system, and we need to have symposia like this on all of those disorders. So I think autonomic testing is actually quite critical, and you need to be sure that this is not another disease of the autonomic nervous system, of which there are many. And, I can say personally, in my medical school, we learned nothing about those diseases, and I struggle to get autonomic disease as part of the medical school curriculum over here at Harvard. So I think we are really poorly educated on these diseases. So we need to talk not just about the postural tachycardia syndrome, and not just about the comorbid and potential underlying diseases of the postural tachycardia syndrome, but about dysautonomia in general. What to do when you find a patient who has these diseases is a challenge. We are, it's not going to be so easy to get patients in to see us. And I warned Lauren about this. I said, we're happy to put on a symposium, but we are not going to be able to deal with patient referrals because, unfortunately, we are, the two of us are booked out a year in advance. And, I don't know if our admin is here. No, she left. But she would kill me if I didn't say this at this session. But, you heard about Dr. Blair Grubb in Ohio, who is really a master of this disease. There are other physicians in town, and Lauren is going to tell you all about those. Our role, and our focus really is to try and understand the biology of this disease. Yeah. We are interested in the research, and we do see patients, but there just are not enough of us to do that.
All I was going to add.
But one more point. But we are very happy to talk to you on the phone, to discuss patients with you, and to do all of those things. And that I want to emphasize. Don't hesitate to call. I'll say me because I don't want to speak for Chris, but I think either of us. Lauren.
I just wanted to say on our website, we have a list of physicians that or doctors can refer their patients to. And it's not a long list because there really aren't a lot of doctors who specialize in it, but there are some other people in the Boston area that are on the list and in other areas too. And, part of the reason that patients are traveling 100 miles for medical care is because most of the top centers, like you guys, don't send people to Grubb. He's got a 3-year wait list. So, okay. But most of the centers have a 6 month to a year or more. So, and the patients want answers right away when they get that primary care doctor or local doctor saying, I think you might have this, and they get very frustrated. And we tell them, okay, get on the waiting list and just do what you can at home with the non-pharmacological stuff. But it's a marathon, not a race. You have to be in this for the long haul and be patient. It's hard to tell that to a patient who's bedridden, but that's the reality.
Okay. There's a question over there, yes.
In my background is I'm a parent of a child with POTS. I've sense a divide in the medical community about the use of steroids for POTS and treatment. And I'm just curious, do you have an opinion on that or a comment about it?
Do you want to answer that one? Or why don't you go ahead and then I'll fill in.
So when you say steroids, do you mean fludrocortisone or do you mean prednisone?
The latter.
Prednisone. So I think at least in terms of specialists who treat autonomic problems, I don't think there's a divide. Prednisone is not an appropriate treatment. I think there's no question about that. Whether there's an underlying autoimmune disorder that might trigger this, that's a separate entity, something within the system, it's attacking itself, causing this. That's a different process, and that might require prednisone or other immunomodulatory therapies as a treatment. So Lauren had suggested Sjogren's syndrome, that is an autoimmune disorder, so that might require immunomodulatory therapy. And autoimmune autonomic ganglionopathy, again, these antibodies that hit the autonomic ganglia, that might require prednisone, and I use that in patients all the time. However, broadly saying just as a treatment for POTS, absolutely not.
Yeah, so I think we're really on the same page with that. I think I like to think of POTS in the setting of what? And, you've heard about POTS in the setting of diabetes, POTS in the setting of Sjogren's syndrome. If the setting is a disease that is an immune-mediated disease, then medications like prednisone and many other medications will have a role. But if it's not in the setting of a disease that is immune-mediated, then steroids and immune modulation, we would say, have no place. Fludrocortisone, on the other hand, as Chris implied, is a stripped-down steroid and has no role in immune modulation and is part of the therapy. Behind you, there was somebody.
A lot of you have mentioned finding underlying other issues that may be causing or exacerbating the POTS. And when I was first diagnosed, which like a lot of you took a number of years to just get the POTS diagnosis, I was seeing a doctor and I noticed that a lot of the medical issues that seemed to either cause or coexist ran in our family. We have mast cell issues in our family, we have thyroid issues in our family, we have autoimmune issues in our family, and so it seemed very unlikely to me that one of those wouldn't be at play given how prevalent they were in my family history. And when I mentioned that to the doctor, he basically told me I was a hypochondriac and I needed to find something else to do and stop bothering him. And then I finally found wonderful doctors, including Dr. Freeman and Dr. Aiken over at Brigham and Women's, who did help me find some of the underlying issues. And then I aged out of my insurance, and so I'm back to square one. And I haven't been able to find specialists who take my insurance. And my primary care tells me to lay off the salt and stop being so lazy. And so I know that physicians are incredibly, they don't have the information that they need or the awareness that they need, and they don't have the facilities even if they do. But what do I do now? Because when I do try to tell doctors that I have these other things, or that I don't need to lay off the salt, then I sort of get labeled as either argumentative or hypochondriac or problematic. And I don't really know what to do.
You go. Yeah, you're right. I think this is, we can answer this, but we won't give good answers. What should she do?
Okay, so you're making us all cry because we've been where you are. I would say you should email us and we will find you a doctor that can help. And I know there's some doctors in this room that could probably help too, depending, I don't know what the insurance status is, but we will find you a doctor because that's what we do.
Yeah. No, and
May I just implore all the doctors in this room? I was diagnosed with systemic mastocytosis years ago, and I was told many times that I was hysterical, that I was trying to get attention from my husband, that I was crazy. As my daughter has been told, that she's hysterical, she's just overthinking everything. As an intelligent young woman, that she needs to stop thinking about it, just live her life. Please, if you don't know, say you don't know. The best thing a doctor ever did for me was to say, I've never heard of systemic mastocytosis. Come back in 2 weeks. I came back in 2 weeks, you knew everything about it. Now, you can't always do that, but you don't just assume that a young woman is hysterical because you don't know what's wrong with her. So many young women have been damaged by doctors.
To add on really, really quickly,
I know the whole look for horses, not zebras, but obviously I come from a family of zebras, and there were so many things that were listed on all the POTS literature that I found that were in my family, and so I didn't understand why doctors would rather think that I was like psychotic or desperate for attention when I'm terrified of needles of doctors, than that I have one of these things that like the last 3 generations of my family has. So if there's a herd of zebras, maybe don't dismiss the zebra.
You know, and you make such an important point, and maybe there are 2 things I want to say. The one is that medical students are trained to think in terms of patterns, and this either fits into something that you've been taught about and that you recognize, or it doesn't. And the knee-jerk reaction, and I think all of us, no matter how sophisticated and how thoughtful one is, the knee-jerk reaction is, I don't know what this is. It doesn't fit into one of the patterns that I know. It must be in your head. And it is really hard to get out of that pattern of thinking, no matter how much on the edge of the known and unknown you are. And those of us who work in research are operating on the edge between the known and the unknown. But even then, it's really, really difficult to do so. But I think that's part of medical education and part of our ongoing education to recognize that if this is not a pattern that one recognizes, learn about it, study it, research it, rather than say that this is in the patient's head. That's the one thing. The other point is that we would never, ever not see a patient because of insurance. I mean, that it's not even, I never know whether a patient has insurance or not. It's a non-issue. So, I just want to make that absolutely clear. I never know, and I'm sure Chris will say the same thing, whether a patient has insurance or not. It's not a question I ever even think of asking.
One more question.
Okay. Any other questions? Okay, I think that's good. Well, thank you very, very much for coming.
Thank you for coming. I just want to say, you can, if you need additional information, you can go to dysautonomiainternational.org. We have a lot of resources for patients and physicians, referrals, places to find other doctors, to find educational material for your patients. So please check it out.